Welcome to the channel. I'm Dr. Zach, and today I want to have a conversation that could genuinely change your life or the life of someone sitting right next to you. We are going to talk about a condition that is, in my clinical opinion, absolutely monstrous in scale and yet almost invisible in our day-to-day healthcare conversations. I'm talking about iron deficiency, not just a little low iron. I mean a chronic, progressive whole-body deficiency that is quietly robbing millions of women of their energy, their mood, their sleep, and their quality of life. Here is a number I want you to sit with. In the United States alone, research suggests that roughly 60% of women of reproductive age have some degree of iron deficiency, either a severe form called iron deficiency anemia or a hidden, earlier form called latent iron deficiency. That is not every other woman, that is more than every other woman. And here is what makes this so alarming. Most of them have no idea. They think the exhaustion is just parenthood. They think the depression is just life. They think the insomnia is just stress. In many cases, the root cause is physiological. It is a micronutrient deficiency that can be detected with a single blood test and treated effectively. So today we are going to build a complete clinical guide right here on this screen. We are going to uncover why the scale of this problem is so immense and why your quality of life is being stolen by a lack of a single micronutrient. We will cover what iron actually does inside your body at the cellular level, how to recognize the signs of deficiency, how to get properly tested, and what modern treatment really looks like. This is not a superficial overview. We are going to go deeper than just eat more spinach. If you are a woman, whether you are a teenager just entering your reproductive years, a young mother in the thick of it, or a woman approaching menopause, please watch this until the very end. And if you know someone who is just tired all the time, please share this video with them. In medicine, caring is sharing. Let's get started. Let's start with the most common question I get in the clinic. Patients come in and they say, "Dr. Zach, how much red meat do I need to eat to fix my iron?" And I understand why they ask that. It's intuitive. You're low on something, so you eat more of it. Simple, right? Except for iron in many women, that logic simply does not hold up. Here's the clinical reality. If you're a healthy adult man with no underlying gastrointestinal issues, eating red meat roughly 3 times a week is generally sufficient to keep your iron store stable. Men have what I call a closed system. They do not lose blood on a regular monthly basis, so the math is fairly balanced. But for women of reproductive age, and we will get into exactly why in a few minutes, the equation is completely different. You could eat 3 rare steaks a day, breakfast, lunch, and dinner, and if you have significant monthly blood loss, that diet alone will not prevent iron deficiency anemia. The outflow pipe is simply moving faster than the inflow pipe can keep up with, no matter what you eat. Now, I want to be honest about food because this is a topic surrounded by myths. I hear them constantly. Eat pomegranates with the seeds and your iron will be fine. Drink beet juice every morning. Eat more apples. These are well-meaning suggestions, but let's look at the science. Pomegranate, beet, and apple are sources of non-heme iron, the plant-based form of iron that the human body absorbs at a significantly lower rate than heme iron from animal sources. And even with good dietary sources, the intestine has a physical ceiling on how much iron it can absorb per day. If your monthly blood loss exceeds what 30 days of optimal nutrition can replenish, you will develop a deficit, period. This does not mean diet is irrelevant. We will absolutely talk about the best food sources for iron at the end of this video. But I want to be clear right now, at the very beginning. For a woman who already has iron deficiency or iron deficiency anemia, you cannot treat that deficiency through diet alone. It is not possible. You need clinical intervention. Food is prevention and maintenance, not a cure. Okay, so now that we've cleared that up, let's talk about what iron deficiency actually looks like on your body. Because for many women, the first signs are hiding in plain sight. Moving on, let's look at the physical warning signs. Physical warning signs from your cells to your skin. The adenosine triphosphate connection, why iron is an energy molecule. Patients often ask me this, what do my cracked heels have to do with my blood? It's a great question, and the answer lives at the cellular level in a tiny organelle called the mitochondrion. Every single cell in your body, from your skin cells to your heart muscle cells, contains mitochondria. These are the power plants of the cell. Their job is to take in glucose and, through a biochemical cascade called the Krebs cycle, convert it into usable energy. That energy is stored in molecules called adenosine triphosphate. Think of adenosine triphosphate as the universal energy currency of the human body. Nothing in your body can happen without it. Muscles contract using adenosine triphosphate. Your immune cells divide using adenosine triphosphate. Your skin cells synthesize the protective proteins they need using adenosine triphosphate. Every process, every function, adenosine triphosphate. Now, here is where iron becomes absolutely essential. Deep inside your mitochondria are structures called mitochondrial respiratory chains. These are the actual molecular tools that carry out the conversion of glucose into adenosine triphosphate. And iron is a mandatory component of those chains. Without sufficient iron, those tools cannot be built correctly. Your mitochondria become inefficient, like a factory running with broken machinery. You are feeding glucose in, but the energy output is drastically reduced. And when your cells cannot make enough adenosine triphosphate, everything downstream suffers. One of the first things to go is protein synthesis, specifically the synthesis of structural proteins. The skin, hair, and nails, your body's sacrifice zone. Your skin is made primarily of a protein called keratin. Your hair is keratin, your nails are keratin. When your cells cannot produce enough adenosine triphosphate to synthesize keratin normally, these structures begin to deteriorate. Here's what that looks like clinically. Xerosis and fissuring, cracked heels, dry skin. The skin cells responsible for maintaining your skin's protective barrier can no longer divide quickly enough or synthesize enough keratin to do their job. The result is skin that becomes excessively dry, rough, and prone to cracking. In some cases, the lower legs and ankles develop what clinicians call a lizard skin texture, a specific pattern of dry, rough, scaling skin that is characteristic of severe iron deficiency. Onychoschitzia and koilonychia. In simpler terms, brittle nails that peel in horizontal layers, that's onychoschitzia. In more advanced cases, the nails can actually become concave, taking on a spoon-like shape. This is called koilonychia, and it is considered a classic clinical sign of significant iron deficiency. Telogen effluvium. This is the medical term for significant hair thinning and hair loss due to a disruption of the normal hair growth cycle. When the hair follicle cells cannot maintain normal function due to low adenosine triphosphate and inadequate protein synthesis, large numbers of hairs simultaneously enter a resting phase and then fall out. Patients often describe finding clumps of hair on their pillow or in the shower drain. This is not normal, and in many cases, when the iron deficiency is corrected, the hair loss reverses. When you see these signs on your own body, I want you to reframe how you think about them. Your body is not just dry or having a bad hair year. Your body is communicating that its cellular energy production has been compromised. It has started rationing resources, and the skin, hair, and nails are the first things it sacrifices to keep your vital organs, your heart, your brain, your lungs running. Iron deficiency masquerading as depression and anxiety. I want to address one of the most significant misdiagnoses I see in clinical practice. Iron deficiency is a master masquerader. It mimics mental health conditions so effectively that a substantial number of patients are being treated for psychological disorders when their underlying problem is physiological. Research suggests that roughly one-third of clinical depression presentations may have an underlying iron-deficient component. Iron-deficient cells in the brain cannot produce neurotransmitters normally, the chemical messengers your brain needs for mood regulation, motivation, focus, and emotional resilience. When your brain's cells are low on adenosine triphosphate and iron, the result can look and feel almost identical to clinical depression or generalized anxiety disorder. The important distinction is this: if you have been experiencing low mood, persistent anxiety, a lack of motivation, and you have already tried antidepressants or therapy with limited success, please consider asking your doctor to check your ferritin level. It is one of the most important things you can do. I've seen patients who had been on antidepressants for years who responded to iron supplementation in a way that no medication had ever achieved. That is not to say that clinical depression is not real, it absolutely is, but iron deficiency can cause a strikingly similar picture, and it is a treatable, correctable cause. Okay, now that you understand what iron deficiency can look like, let's figure out whether you might have it. The 5-question screening protocol. I want to do something practical right now. Before we go further into the science and treatment, I want you to perform a brief self-screening. I've formulated 5 critical questions that every woman should be asking herself. Depending on how many yes answers you have, it will be very clear whether this video should send you directly to your doctor to request a blood test. Question 1. Do you have enough energy for your own life? I'm not talking about the normal tiredness that comes from a long workday or a sleepless night with a newborn. I'm talking about a deep, pervasive, unexplained lethargy, a feeling of physical and mental exhaustion that persists even after rest, an energy deficit that does not resolve, that continues for months, sometimes years, regardless of how much you sleep, how well you eat, or how little stress you have. This is one of the most fundamental symptoms of iron deficiency, and it traces directly back to what we just discussed. Your entire body, every single cell, depends on iron to produce energy. When you are iron deficient, literally every system in your body is operating below its capacity. The fatigue is not in your head, it is in your mitochondria. If you answered yes to this question, if you are living with unexplained, persistent fatigue, that alone is reason enough to get tested. You do not need to continue through the remaining 4 questions. Make the appointment. Question 2. How is your emotional and mental state? As I mentioned earlier, iron deficiency can mimic depression and anxiety disorder. Ask yourself, are you experiencing persistent low mood, a lack of motivation, a loss of interest in things that previously brought you joy? Are you more anxious than usual with no clear external reason? Have you tried counseling or medication and found limited relief? Again, I am not dismissing clinical depression or anxiety as real conditions. They absolutely are. But if your symptoms have been present for a long time, if they are resistant to standard treatments, and if they came on gradually alongside other possible iron deficiency symptoms, then there is a real clinical possibility that the problem is somatic, not purely psychological. Check your iron. It is a simple blood test. Question 3. Are you sleeping well, truly sleeping? Disrupted sleep is one of the earliest and most underrecognized symptoms of iron deficiency, and the specific pattern matters. I want you to think about this. Do you find yourself waking at 3 or 4 in the morning, fully awake despite being exhausted? Do you feel wired but physically tired? Do you fall asleep quickly but wake throughout the night, unable to reach deep, restorative sleep? These patterns, early morning awakening, fragmented sleep, architecture, are characteristic of iron deficiency, especially in adult women. We also see significant sleep disturbance in pregnant women with iron deficiency and in children. If your sleep has been consistently poor and you cannot explain it by lifestyle factors like a disruptive schedule or known sleep apnea, iron deficiency deserves to be on the list. Question 4. Are your skin, hair, and nails deteriorating? We covered this in detail in the previous section, but I want you to take an honest inventory right now. Are your nails brittle? Do they peel easily? Have you noticed more hair in your shower drain than usual, or a visible thinning at your temples or part line? Is your skin excessively dry, rough, or flaky in ways that do not respond to moisturizer? These are not vanity concerns. These are clinical data points. Your skin, hair, and nails are the first structures your body deprioritizes when adenosine triphosphate production drops. If they are visibly suffering, your internal stores are likely suffering too. Question 5. Are you getting sick too often? Think about how often you come down with a cold, flu, or other viral infection compared to the people around you. Do simple infections tend to progress into something worse, ear infections, sinusitis, lingering coughs? Does it take you significantly longer than other people to recover? Iron is absolutely essential for immune function. Your white blood cells, the soldiers of your immune system, need iron to divide rapidly when an infection is detected. They also need iron and adequate adenosine triphosphate to synthesize immunoglobulins, which are the antibody proteins that neutralize viruses and bacteria. Without enough iron, your immune cells literally cannot keep up with the demand. The immune response is slow, the cells are weak, and infections run longer and harder. If you answer yes to all 5 of these questions, I want to say this as directly as I can. Please give yourself the gift of a blood test. Go and get your complete blood count and your serum ferritin measured. We will talk about exactly what those tests mean and how to interpret the number shortly. But first, let's make sure you understand the biology of what we are dealing with. Let's move on to the science. What is iron? Why does your body need it? And how does a deficiency actually develop? Iron Biology 101, the body's cellular currency. Let's start from the very beginning because I think the best way to truly understand and care about iron deficiency is to understand what iron actually does in your body. Iron is a micronutrient, a mineral that the body requires in relatively small amounts compared to, say, calcium or protein, but small amount does not mean minor importance. Iron is one of the most fundamentally essential elements in human physiology, with a role in cellular energy that goes back to the very beginning of life on Earth. Billions of years ago, when the first single-celled organisms evolved in Earth's primordial oceans, those ancient seas were rich in iron. Early life forms had to learn to use iron or be killed by it. Over time, cells evolved mechanisms to incorporate iron into specific proteins, and those proteins became essential tools for energy production. We have been carrying that evolutionary legacy ever since. Today, iron is integrated into virtually every cell in the human body. Even before we talk about hemoglobin, which everyone knows is iron-containing, every single cell contains iron-based proteins that are universal across all cell types. The most critical example, the mitochondrial respiratory chains we discussed earlier. Without those iron-containing structures, cells cannot run their energy-generating machinery efficiently. The 3 iron pools in your body. The average adult human body contains approximately 5 grams of iron, that is 5,000 milligrams. To put that in perspective, it is a very small amount physically. If you could extract all the iron from your body and hold it in your hand, it might fill a small thimble, yet its absence causes the body to begin breaking down. This iron is distributed across 3 distinct pools, or compartments. Pool 1, the hemoglobin pool, approximately 70%. The largest share of your body's iron lives inside your red blood cells, bound to a protein called hemoglobin. Hemoglobin is a complex iron-containing protein whose primary job is to bind oxygen in the lungs and carry it through the bloodstream to every cell in the body. Every red blood cell is essentially a tiny oxygen delivery vehicle, and iron is the part that actually grabs and holds the oxygen. When hemoglobin-rich red blood cells circulate through your lungs, iron in the hemoglobin picks up oxygen. When those red blood cells reach a muscle or an organ, the iron releases that oxygen to the waiting cells. This is the most important function of iron in the body, oxygen transport. Pool 2, the tissue and functional pool, approximately 20%. This is the iron that is at work inside your body's tissues, not in the blood, but inside individual cells. This includes myoglobin, an iron-containing protein in your muscle cells that stores oxygen for use during physical activity. It also includes those mitochondrial respiratory chain proteins we discussed. This tissue iron is functional iron. It is actively in use and cannot easily be redirected elsewhere. When iron deficiency progresses, the body can pull from this pool, but doing so compromises cellular energy production and muscle function. Pool 3, the storage pool, or ferritin, approximately 10%. This is the reserve. This is your savings account, located primarily in the liver. Inside liver cells, a remarkable protein called ferritin acts as a safe storage container, capable of holding large numbers of iron atoms in a stable, non-toxic form. When the body needs more iron than it is currently receiving from food, it can draw on these ferritin stores. When you have a surplus of iron coming in, the body replenishes these stores. The level of ferritin in your bloodstream, what we call serum ferritin, is the single most accurate clinical indicator of whether your iron stores are adequate, depleted, or overloaded. The reservoir analogy, how iron deficiency actually develops. I want you to picture a swimming pool. There is a pipe on one side filling it with water. That is your dietary iron intake, the iron your intestines absorb from food each day. On the other side, there is a drain. That is your iron usage and your iron losses. In a perfectly balanced system, the inflow and the outflow are equal, and the water level stays constant. In a man who is not donating blood and does not have a gastrointestinal condition, this balance is almost always maintained without much effort. But in a woman who menstruates, the drain gets periodically wider every month, sometimes dramatically wider. If the drain is consistently wider than the pipe filling the pool, the water level, your ferritin level, begins to drop. Slowly at first, then faster, until eventually the pool is empty. That empty pool is iron deficiency anemia. But there is an important stage in between when the pool is running low but is not yet empty, and that is called latent iron deficiency or iron deficiency without anemia. And this middle stage is where most women with iron deficiency actually are. Their hemoglobin is still normal, their red blood cells look fine on a standard blood count, but their ferritin stores are depleted, their cells are starting to starve for iron, and the symptoms have already begun. Now here's the crucial part, the body's priority system and why it makes you feel terrible before it shows up on a basic blood test. Two stages of iron deficiency, latent versus anemia. This is one of the most clinically important concepts I will cover in this entire video, and it is also one of the most underappreciated. The human body has a single overriding priority when it comes to iron: prevent hypoxia. Hypoxia means insufficient oxygen delivery to the tissues. At the cellular level, oxygen deprivation is acutely dangerous. Cells begin to malfunction and die within minutes in severe cases. So the body has evolved a powerful iron prioritization system, and that system, in the context of iron deficiency, is actually the reason you can feel terrible for months or years before a standard blood test shows anything wrong. Stage 1, latent iron deficiency, also called iron deficiency without anemia. When your ferritin stores begin to deplete, the body does not immediately reduce hemoglobin, instead it goes into triage mode. The bone marrow, which is the organ responsible for producing new red blood cells, is the body's most demanding iron consumer. It needs a steady supply of iron to produce new red blood cells every single day, because red blood cells have a lifespan of only about 120 days. When old ones are destroyed in the liver and spleen, the bone marrow must produce new ones to replace them. If the ferritin stores in the liver run low, the bone marrow does not slow down. It cannot afford to. Instead, it does something more aggressive. It begins to pull iron away from other tissues. It takes iron from your brain cells, your skin cells, your immune cells. The body's logic is brutal but straightforward. I do not care if your hair falls out. I do not care if you cannot concentrate. I do not care if your immune system is compromised. What matters is that there are enough red blood cells to carry oxygen. Hypoxia must be prevented. The result? Your hemoglobin levels remain normal on a blood test. A doctor looks at your complete blood count and says, everything looks fine. But your brain, your skin, your muscles, and your immune system are being robbed. This is latent iron deficiency, and it is why you can feel absolutely terrible while your routine blood work is normal. The symptoms are real, the deficiency is real, but it will not show up on hemoglobin alone. This stage can last for months, sometimes years, without ever progressing to anemia, if the iron losses are significant enough to deplete stores, but not so rapid as to overwhelm the bone marrow's ability to compensate. Stage 2. Iron deficiency, anemia. Eventually, if the depletion continues and the iron stores are fully exhausted, the bone marrow can no longer make enough hemoglobin to keep red blood cell levels normal. The red blood cells it produces become smaller and paler than normal. This is called microcytosis and hypochromia. The hemoglobin level begins to drop below the normal physiological range. This is the clinical definition of anemia. Anemia, a condition in which hemoglobin concentration falls below the normal physiological threshold, below 120 grams per liter, in non-pregnant women, below 130 grams per liter in men, and variable by age in children. Once hemoglobin falls below that threshold, the body's oxygen transport capacity is genuinely compromised. Tissues throughout the body begin to experience mild but chronic hypoxia. Symptoms become more severe and more pervasive. The heart works harder, exercise tolerance drops sharply, cognitive function deteriorates, and the immune system becomes significantly more vulnerable. Here's the critical clinical message: you do not need to be anemic to be suffering from iron deficiency. Latent iron deficiency, to the stage before anemia, is responsible for the vast majority of symptoms, and because hemoglobin appears normal at that stage, it is routinely missed unless ferritin is specifically measured. This is why ferritin testing is not optional, it is essential. Moving on, now let's talk about why iron deficiency is so overwhelmingly more common in women than in men. Why women? The epidemiology of iron deficiency, I want to share some statistics with you because I think numbers help make the scale of this problem real in a way that words alone cannot. There was a particularly illuminating study conducted in Iceland in 2017. Researchers looked at the ferritin levels of first-time blood donors, people who had never donated blood before and were doing so for the first time. These were healthy individuals, presumably with no known iron deficiency diagnoses. And what they found was striking. Among the male first-time donors, only about 1% had iron deficiency at the time of their first donation. Among the female first-time donors, 22%, more than 1 in 5, were already iron deficient before they ever donated a single drop of blood. That is an enormous gender disparity, and it tells us something profound. Iron deficiency in women is not primarily caused by blood donation or some unusual circumstance. It is caused by the baseline conditions of female physiology. In the United States, current data suggests that approximately 20% of women of reproductive age have iron deficiency anemia, the severe form, and another 40% or so have latent iron deficiency, the hidden form. When you add those together, you are looking at roughly 60% of women in their reproductive years with some degree of iron deficiency, more than half. The reproductive age window, the period of greatest risk. When we look at iron deficiency epidemiology across the female lifespan, a very clear pattern emerges. Before menstruation begins, in childhood and early adolescence, iron deficiency is relatively uncommon, assuming adequate nutrition. After menopause, as menstruation ceases, the incidence of iron deficiency in women drops significantly, and ferritin levels actually begin to rise. In fact, postmenopausal women often have ferritin levels similar to those of men, but the years between the first menstrual period and menopause, roughly ages 12 to 50, though this varies, this is the period of highest risk. And within that window, there are peaks of extreme vulnerability. Pregnancy is the most significant of these peaks. During a single pregnancy, a woman's body requires approximately 500 milligrams of additional iron to support fetal growth, to expand her own blood volume, and to cover the blood loss at delivery. That 500 milligrams is precisely equal to the total amount of iron the body can store in a full ferritin depot. In other words, if a woman begins pregnancy with excellent iron stores and perfect ferritin, she will likely use all of it over 9 months. And in the real world, many women begin pregnancy with ferritin stores that are already below optimal because their years of menstrual loss have already depleted their reserves before they ever conceived. The result is iron deficiency during pregnancy, postpartum iron deficiency, and the cycle continues. The menstruation conversation we are not having. Here is something I want to address directly because it is a significant driver of this epidemic. Menstruation is, for most women, a private matter. It is not a common topic of conversation, and because of that, very few women have ever had an accurate comparison point for what is and is not a normal menstrual volume. Your period has probably been exactly this heavy since your very first cycle, and if it has always been this way, it can feel normal, even when it objectively is not. Research from gynecology literature suggests that approximately 40% of women who objectively have heavy menstrual blood loss, what we clinically call menorrhagia, believe their blood loss is normal. They are not in denial. They simply have no reference point. No one told them. It was never discussed. So let's discuss it now. Here's the clinical standard for menstrual blood loss and how to know if you are exceeding it. The 80 milliliter rule. Quantifying your menstrual blood loss. The clinical threshold for normal menstrual blood loss is 80 milliliters per cycle. That is the number. If you lose less than 80 milliliters of blood over the course of your entire menstrual period, your intestines can, in most cases, with a reasonably iron-sufficient diet, absorb enough iron each month to replace what you lost. Your ferritin stores can be maintained, but if you consistently lose more than 80 milliliters per cycle, and many women lose 100, 150, 200, or even more, then no matter what you eat, you are in a state of chronic iron depletion. Month after month, your reserves go down a little more until the symptoms appear. Now, most women do not have precise laboratory measurements of their menstrual loss. So how do you assess it practically? How to assess your menstrual volume without a lab? The night pad indicator, the first and most important clinical red flag is whether you require overnight absorbency pads or tampons during the daytime. These products are designed to absorb significantly higher volumes than standard daytime products. If you feel comfortable only with the largest available products during the day, Super, Super Plus, or overnight size, you are likely losing a substantial amount of blood. The 2-hour saturation rule: if you are saturating a large pad or tampon in 2 to 3 hours, meaning it is completely full during the heaviest days of your period, that is a clinical sign of heavy menstrual bleeding. If this happens consistently for 1 or more days per cycle, you are very likely losing more than 80 milliliters per cycle. Nighttime changes. If you need to wake up in the middle of the night to change your sanitary product to prevent leaking, that is significant blood loss. The menstrual cup method: if you use a menstrual cup, you have an excellent opportunity to measure your loss directly. The cup has volume markings and you can track exactly how many milliliters you are losing on each day and over the full cycle. This is actually the most precise method available without laboratory testing, and I encourage any woman who wants to understand her flow to try it. The weigh and calculate method: for those who prefer pads or tampons, you can actually weigh a used product on a small kitchen scale. A gram of absorbed fluid is approximately equivalent to 1 milliliter in volume. Weigh each product after use, subtract the dry weight, usually printed on the package, add up the totals across your full period, and you have a reasonably accurate estimate. I want to emphasize that the number of days your period lasts is less important than the volume lost on each day. Some women have 3-day periods that are so heavy in the first 2 days that they lose 200 milliliters total. Others have 7-day periods that are consistently light throughout. The volume is what matters for iron balance, not the duration. If your assessment suggests you are consistently losing more than 80 milliliters per cycle, I strongly encourage you to discuss this with a gynecologist. We will talk about the clinical options for managing heavy menstrual bleeding later in this video, but for now, the key takeaway is heavy menstrual bleeding is not something you should simply accept as your normal. It is a clinical condition with real treatable causes, and it is the primary driver of iron deficiency in women of reproductive age. Next, genetics. Can iron deficiency be inherited, and are there genetic conditions that can mimic it on blood tests? Genetics. When your DNA plays a role. Epidemiology, the rare direct genetic cause. There is a rare genetic condition that directly affects iron absorption, and it is worth knowing about even though it affects a very small number of people. It is called IRIDA, which stands for iron refractory iron deficiency anemia. In IRIDA, a mutation affects the receptors and channels in the cells of the small intestine that are responsible for absorbing iron from food and from oral iron supplements. When these receptors are damaged or non-functional, the person cannot absorb iron through the gut at all. Not from food, not from oral supplements, not from vitamins. The result is a severe iron deficiency anemia that begins in early childhood and does not respond to any oral iron therapy. IRIDA is considered an orphan disease, which in medical terminology means it is extremely rare. A hematologist who has encountered even 2 or 3 cases in their career has seen more than most. Because IRIDA causes severe, obvious anemia from a very young age, it is typically diagnosed in childhood. If you are an adult who has recently learned about iron deficiency, IRIDA is almost certainly not your diagnosis. But it is worth knowing that this condition exists, because it is the one scenario in which oral iron supplementation will never work, and intravenous iron is the only effective treatment. Thalassemia, the condition that mimics iron deficiency. This is clinically very important, and I want to make sure every person watching understands it clearly. Not all anemia is caused by iron deficiency. There are dozens of different causes of anemia. Iron deficiency is by far the most common worldwide, but it is not the only cause, and there is one genetic condition in particular that is critically important to distinguish from iron deficiency anemia: thalassemia. Thalassemia is a group of inherited disorders that affect the genes responsible for producing hemoglobin. The hemoglobin produced in thalassemia is structurally abnormal, and as a result, the red blood cells are smaller than normal and more fragile. On a standard complete blood count, thalassemia produces a picture that looks almost identical to iron deficiency anemia. Small red blood cells, low hemoglobin, pale red blood cells. Without additional testing, it can be very easy to confuse the two. The severe forms of thalassemia, thalassemia major, and thalassemia intermedia cause serious illness from infancy, requiring regular blood transfusions. These conditions are almost always diagnosed in the first year of life. If you have one of these, you already know. What is more likely to cause diagnostic confusion is a much milder form called thalassemia minor, also referred to as thalassemia trait. People with thalassemia minor have inherited only one copy of the abnormal hemoglobin gene. They are carriers. Their red blood cells are smaller and paler than normal, and their hemoglobin is mildly reduced, sometimes sitting at 100 to 110 grams per liter for women. But they do not have the severe hemolysis, the abnormal destruction of red blood cells seen in the major forms. They are often completely asymptomatic, or only mildly so, and many go their entire lives without a diagnosis. The problem arises when a doctor sees a blood count that looks like iron deficiency anemia and prescribes iron. For a thalassemia minor patient, iron will not improve the anemia because the anemia is caused by a structural problem in the hemoglobin genes, not by a lack of iron. In fact, if a patient already has adequate or elevated iron stores, unnecessary iron supplementation can potentially cause harm over time. If you have taken iron supplements or received IV iron infusions for what you were told was iron deficiency anemia and your blood count has not improved, please ask your doctor to rule out thalassemia. A simple additional blood test, hemoglobin electrophoresis, can confirm or rule out thalassemia minor. Thalassemia minor is particularly common, though not exclusive, in populations with ancestral ties to the Mediterranean region, Central Asia, the Middle East, and coastal India. This includes people of Italian, Greek, Turkish, North African, South Asian, and many Central Asian ethnic backgrounds. Good. Now let's talk about a group that often gets overlooked in iron deficiency conversations: teenagers. Teenagers and iron deficiency, a vulnerable, overlooked group. I want to take a moment to specifically address teenagers because adolescence is actually one of the highest risk periods for iron deficiency, and it is often the least recognized. Teenagers, both boys and girls, share one major iron depleting risk factor: the adolescent growth spurt. Between approximately ages 12 and 16, the average adolescent undergoes a period of dramatically accelerated cell division. The body is building new muscle, new bone, new organ tissue at a rate that will never be matched again in adult life. This rapid growth requires enormous quantities of iron because every dividing cell needs iron for its mitochondria, and the growing red blood cell mass alone demands significant additional iron resources. Ferritin stores that a child built up during the relatively slower growth years of middle childhood can be depleted during this growth spurt. By the time the growth phase ends, both boys and girls may have ferritin levels lower than they started with. For boys, this is usually a temporary issue. After the growth spurt, their iron demand stabilizes, they eat more food, often substantially more, and their stores recover. For girls, the situation is more complex and more serious because immediately after the growth spurt depletes their ferritin, menstruation begins. So the girl who was energetic, athletic, excelling academically, and participating in multiple extracurricular activities, suddenly at age 13 or 14 begins to feel exhausted. She gets frequent headaches. She wants to nap after school. She loses enthusiasm for activities she previously loved. She struggles to concentrate in class. Headaches, a common but under-recognized symptom. Headaches are one of the most common symptoms of iron deficiency in teenagers and in adult women as well. They are frequently misattributed to stress, dehydration, eye strain, or tension. In some cases, they are misdiagnosed as migraines and treated with pain medications that provide only temporary relief. The mechanism is related to the brain's oxygen supply. When the tissue iron pool is being depleted and brain cells are receiving less iron and producing less adenosine triphosphate, the cerebral blood vessels may respond with vasodilation, causing vascular headaches. Additionally, as anemia progresses and hemoglobin drops even slightly, oxygen delivery to the brain is reduced, which can trigger headache as well. The good news, headaches that are caused by iron deficiency often resolve completely when the iron deficiency is properly treated. I have seen teenage girls who have been managing migraines for 2 or 3 years become essentially headache-free after a course of iron supplementation. It is one of the most gratifying outcomes in hematology. If you have a daughter, a niece, a student, or a young woman in your life who has recently started menstruating and has begun showing signs of fatigue, mood changes, poor concentration, frequent headaches, or declining athletic or academic performance, please think about iron deficiency. I encourage her parents to have her ferritin checked. It is a simple blood test, it is inexpensive, and the difference it can make in a young woman's life during these critical years can be immeasurable. Many women, looking back on their teenage years after eventually receiving an iron deficiency diagnosis in adulthood, recognize with sadness how much that deficiency affected them during school, during university, during the years when they were supposed to be at their most energetic and capable. The question that haunts them is, why didn't anyone check? Let's change that. Let's now talk about the practical steps. How do you actually get tested, and what does that test involve? Getting tested, what to request, and how to prepare. If there is one practical action step you take away from this video, I want it to be this. You need 2 specific blood tests, and you need to know how to prepare for them correctly so the results are accurate. The 2 tests are a complete blood count, also called a CBC, and a serum ferritin test. Test 1, the complete blood count, CBC. A CBC gives your doctor a comprehensive picture of all the major cell types in your blood. It measures your hemoglobin level, the primary indicator of anemia. It also measures the number, size, and color intensity of your red blood cells. 2 key measurements within the CBC are the MCV, mean corpuscular volume, which tells us the average size of your red blood cells, and the MCH, mean corpuscular hemoglobin, which tells us how much hemoglobin is packed into each red cell. In iron deficiency anemia, red blood cells become smaller than normal. This is microcytosis, and paler than normal. This is hypochromia. These changes can show up on a CBC even before hemoglobin itself falls below the diagnostic threshold for anemia, and they give an experienced clinician useful early signals. If you are tested outside of the United States and in Spain, Italy, or other European countries, for example, this test may be referred to as a hemogram. Regardless of the name, you want the full panel that includes hemoglobin, red blood cell count, MCV, and MCH at a minimum. Test 2. Serum ferritin. Serum ferritin is the single most important test for iron deficiency. It directly reflects the size of your iron storage pool. A low serum ferritin is essentially diagnostic of iron deficiency, even if your hemoglobin is completely normal. This is how we detect latent iron deficiency before it progresses to anemia. I want to add an important nuance here. Ferritin is what biochemists call an acute phase reactant. This means that during active infection, inflammation, or certain autoimmune conditions, the liver produces more ferritin than usual, and your serum ferritin level may be falsely elevated. In other words, if you are sick when you get tested, your ferritin might look normal even if your actual iron stores are depleted. Similarly, in patients who are significantly overweight or obese, the chronic low-grade metabolic inflammation associated with obesity can keep ferritin levels artificially elevated. The practical implication: whenever possible, get your ferritin tested when you are healthy, not during or within 3 to 4 weeks of a significant illness. How to prepare for these tests. Fast before the test. These blood tests should be taken in a fasted state, meaning nothing to eat, and no tea, coffee, juice, or any caloric beverage for several hours beforehand. A cup of coffee can alter certain blood components and interfere with accurate measurement. Water is completely fine and actually encouraged. Drink water. This is important and often overlooked. When you arrive at the lab in the morning without having eaten or drunk anything, your blood is slightly more concentrated and your blood vessels may be slightly more contracted. Drinking 2 to 3 full glasses of water before your blood draw will improve your blood pressure in the vessels, make the blood flow more freely, and often make the draw easier and more comfortable. No smoking for 30 minutes before the draw. This is a standard pre-laboratory instruction for most blood tests. Pause iron supplements 72 hours beforehand. If you are currently taking oral iron supplements, stop taking them 3 days, 72 hours before your ferritin test. Taking iron shortly before the test can cause a transient elevation in certain iron-related markers and may reduce the accuracy of the result. Avoid strenuous exercise 12 hours before the test. Intense physical activity can temporarily alter certain blood parameters. A gentle walk is fine. A hard workout is not ideal before a blood draw. Timing relative to your menstrual cycle. For women with heavy periods, the most informative time to test ferritin is in the week or two after your period has completely ended, not during the period and not immediately after. This allows the most recent blood loss to be reflected in your ferritin level, giving you and your doctor the clearest picture of where your stores truly stand. A note on other iron-related tests. You may have heard of serum iron transferrin and transferrin saturation tests. These are sometimes ordered as part of what is called an iron panel or iron metabolism panel. While these tests have their place in specific diagnostic scenarios, they are not necessary for standard screening. Serum ferritin alone is the most reliable and clinically sufficient marker for iron deficiency in the vast majority of situations. There is no need to order an extensive panel unless your physician has a specific clinical reason to do so. Okay, you've got your test results back. Now, what do the numbers actually mean? Before going into the details, I will ask you to hit the like and subscribe button, which would help me a lot. Understanding your results. The numbers that matter. This is one of the most important parts of this video, and I want you to pay close attention because the normal ranges printed on many standard lab reports are outdated and may cause your doctor to miss a real deficiency. Ferritin. The diagnostic threshold. The clinical standards for ferritin have been revised upward 3 times over the past 25 years as research has accumulated. For a long time, a ferritin above 15 micrograms per liter was considered acceptable. Then the standard moved to above 30. These thresholds were too low, and they allowed many symptomatic patients to be told their results were normal when they were actually iron deficient. As of 2020, the American Gastroenterological Association published updated clinical practice guidelines establishing a ferritin below 45 micrograms per liter as the diagnostic threshold for iron deficiency. If your serum ferritin is below 45 micrograms per liter, you have iron deficiency, regardless of what the lab report's reference range says, and regardless of whether your hemoglobin is normal. This finding alone is sufficient to diagnose iron deficiency and initiate treatment. Please be aware that many hospital and clinic laboratory systems have not yet updated their reference ranges to reflect the 2020 American Gastroenterological Association guidelines. Your lab report may still show the old threshold, 15 or 30, as the lower limit of normal. This does not mean your ferritin of 38 is fine. Based on current evidence-based guidelines, it is not. If your ferritin is below 45, have a conversation with your doctor about treatment. Hemoglobin. The anemia threshold. For hemoglobin, the clinical thresholds are as follows. A hemoglobin below 120 grams per liter in a non-pregnant woman is considered anemia. For men, the threshold is below 130 grams per liter. For children, it varies by age, but for most school-age children, below 120 grams per liter is generally the clinical cutoff. If you are pregnant, slightly different thresholds apply, and iron supplementation and ferritin monitoring should be a standard component of your prenatal care from the very beginning of pregnancy. Ferritin. What are we actually aiming for? Here is a nuance that is rarely discussed. There is a difference between the ferritin level at which you are considered deficient, the diagnostic threshold, and the ferritin level at which you actually feel well and function optimally. These are 2 different numbers. The best way to get a sense of an optimal ferritin target is to look at what men naturally achieve without blood loss or pregnancy, because men are essentially the control group for iron status. A healthy 40-year-old man with no iron-related conditions and no unusual iron losses will typically have a ferritin somewhere between 100 and 180 micrograms per liter. A man approaching 50 may have ferritin above 200. These are the levels at which men report no fatigue, no mood disturbances, no sleep disruption, and robust exercise tolerance. Research on specific symptom resolution gives us additional guidance. For example, for patients with restless leg syndrome, a specific sleep disorder associated with iron deficiency, clinical studies have found that symptoms significantly improve or resolve when ferritin is raised to above 75 micrograms per liter. For women with heavy menstrual blood loss, the British Committee for Standards in Hematology recommends a pre-surgery ferritin of above 100 micrograms per liter to reduce the likelihood of needing a blood transfusion after significant surgical blood loss. And for pre-pregnancy optimization, a ferritin of approximately 150 micrograms per liter or higher is associated with sufficient stores to sustain a full pregnancy without developing deficiency. Based on these data points, while the diagnostic threshold is 45, a practical clinical target for women who want to feel well, exercise well, sleep well, and maintain immune resilience is likely around 100 to 150 micrograms per liter. That is the range to discuss with your doctor when establishing a treatment goal. Speaking of restless leg syndrome, let's take a few minutes to really understand this condition because it is one of the most under-recognized consequences of iron deficiency. Restless leg syndrome, the sleep disorder, linked to your iron. Restless leg syndrome, commonly abbreviated as restless leg syndrome, is a neurological sleep disorder that is studied by somnologists, physicians who specialize in sleep medicine. It is more common than most people realize, and its connection to iron deficiency is one of the most well-established and clinically important links in hematology. Here's what restless leg syndrome actually feels like, so you can recognize it if you or someone you know experiences it. In the hours before sleep or during periods of prolonged rest or sitting, people with restless leg syndrome experience intensely uncomfortable sensations in their legs. The sensations are difficult to describe. Patients use words like crawling, tingling, aching, electric, or creeping. The legs feel restless, as though they have to be moved. There is an irresistible urge to stretch, shake, or kick the legs. Soaking in a hot bath or pressing the legs against a cool wall may bring temporary relief, but the sensations return as soon as the person tries to settle. These sensations make it extremely difficult to fall asleep, and for some patients, the leg movements continue during sleep itself, causing involuntary kicks and jolts that repeatedly wake them, and sometimes their sleeping partners, throughout the night. Restless leg syndrome can cause profound chronic sleep deprivation and significantly reduces quality of life. The underlying mechanism involves the neurotransmitter dopamine. Dopamine is produced by specific nuclei in the brain and plays a critical role in regulating sleep architecture. The pattern of deep and light sleep cycles throughout the night. Patients with restless leg syndrome have a disrupted circadian rhythm of dopamine production. The amount of dopamine available in the brain at night is insufficient to properly regulate sleep depth and leg movement inhibition. This is where iron enters the picture. Iron is a required cofactor for the enzymes that synthesize dopamine in the brain. If iron levels in the central nervous system are insufficient, which can happen when serum ferritin is low, even if peripheral hemoglobin is normal, dopamine production is impaired. In people who have a genetic predisposition toward disrupted dopamine rhythm, this iron deficiency in the central nervous system can be enough to trigger full restless legs syndrome symptoms. The treatment evidence is compelling. Sleep medicine researchers have demonstrated that when ferritin levels in restless leg syndrome, patients are raised to above 75 micrograms per liter through iron supplementation, either oral or intravenous. The majority of patients experience significant improvement or complete resolution of their symptoms. Iron is now considered a first-line treatment for restless leg syndrome in patients with low or borderline ferritin. If you or someone you know has been diagnosed with or suspects restless leg syndrome, please ask for a ferritin test. If ferritin is below 75, correcting the iron deficiency should be the first step in treatment before pharmaceutical sleep medications are considered. Now let's talk about treatment. What are the options and what works best? Treatment are oral iron versus IV iron. When it comes to treating iron deficiency, there are two primary clinical options: oral iron supplementation and intravenous iron infusion. Both are effective. The right choice depends on the severity of the deficiency, the presence of gastrointestinal issues, the patient's individual tolerability, and practical considerations like cost and access. Oral iron supplements have been the first-line treatment for iron deficiency for decades. When the correct formulation is used at the right dose and when the risk factor causing the deficiency is being addressed simultaneously, oral iron is highly effective in most patients. The key phrase here is the correct formulation. Not all iron supplements are equal. The ingredient that matters is the active form of iron. In hematology, the gold standard for oral iron therapy is ferrous sulfate, also written as iron 2-sulfate. This is the classic, most studied, and most clinically validated form of oral iron. It has been on the market for decades under many different brand names. In the United States, commonly available oral iron products containing ferrous sulfate include Feosol and Ferrinsol, among others. In European markets, Ferigrad and the German preparation Ferrosanol are well-known options. In many countries, tardifarin is a standard prescription formulation. These are not endorsements. I'm simply noting that if you see ferrous sulfate on the label as the active ingredient, you have a clinically proven formulation. What I want you to be cautious of, the iron supplement market is filled with products that contain forms of iron that are less bioavailable, more expensive, and less clinically validated, such as chelated iron, carbonyl iron, or gentle iron formulations that are marketed as causing fewer side effects. While some patients do tolerate these better, their efficacy is often lower. If ferrous sulfate is causing you gastrointestinal discomfort, the solution is usually not to switch to a less effective form. It is to adjust how you are taking the ferrous sulfate. The most common side effects of oral iron are gastrointestinal, nausea, stomach cramping, and constipation. These are real and they cause many patients to discontinue oral iron prematurely. The good news is that they are largely manageable with adjustments to the timing and method of administration. How to take oral iron for best results. Ideal timing, before bed, 2 hours after dinner, taking oral iron on a completely empty stomach, the classic first thing in the morning. Our recommendation does maximize absorption, but it also maximizes gastrointestinal irritation. For most patients, a more tolerable and still very effective approach is to take oral iron approximately 2 hours after your evening meal and before going to sleep. This way, the stomach is mostly empty, absorption is good, and you sleep through any potential mild discomfort. Take with vitamin C. Vitamin C, ascorbic acid, enhances non-heme iron absorption in the gut. You do not need a large dose. A glass of orange juice containing 70 to 80 milligrams of vitamin C is perfectly sufficient. Alternatively, a vitamin C supplement of 250 to 500 milligrams alongside your iron tablet will do the same job. This is the one well-supported nutritional strategy for improving iron absorption. Separate iron from calcium, tea, and coffee. These three are iron's enemies. Calcium, whether from dairy products, calcium-fortified plant milks, or calcium supplements, binds to iron in the gut and dramatically reduces absorption. Tea and coffee contain compounds called polyphenols and tannins that similarly inhibit iron uptake. If you take your iron at bedtime 2 hours after dinner and you have your dairy products and morning coffee at breakfast, there is no conflict. Do not take with magnesium supplements. Like calcium, magnesium can also interfere with iron absorption. If you take a magnesium supplement for sleep or muscle cramps, which many people do, take it at a separate time from your iron. Intravenous iron, fast, effective, and increasingly safe. Intravenous iron has been available for many decades, but the formulations used 30 or 40 years ago carried a higher risk of adverse reactions, including serious allergic type reactions, than modern formulations do. As a result, IV iron developed a reputation for being risky, reserved only for the most severe cases. That reputation is now outdated, and it is important to correct it. The newest generation of intravenous iron formulations, which have been extensively studied over the past 15 years in large populations, including pregnant women, patients with kidney disease, patients with inflammatory bowel disease, and many others, have an excellent safety profile. A landmark 2020 consensus paper published in The Lancet Hematology reviewed a comprehensive meta-analysis of IV iron safety data and concluded that modern intravenous iron formulations are as safe as oral iron supplements in terms of serious adverse events. The most well-studied modern IV iron preparation is ferric carboxymaltose, which is marketed under names such as Injectafer in the United States. One of its major clinical advantages is that a full therapeutic dose of 500 milligrams of iron can be administered in a single infusion in a single clinic visit in 15 to 30 minutes. This is highly convenient for patients who need rapid repletion. For a woman with latent iron deficiency, normal hemoglobin but low ferritin, the standard treatment dose is typically 500 milligrams of intravenous iron. For women with actual iron deficiency anemia, the dose is calculated using a specific formula based on the patient's current hemoglobin level and body weight. The deficit is larger and the dose accordingly higher. There are also generic IV iron formulations, earlier generation compounds made by various manufacturers that are less expensive than ferric carboxymaltose and require the same 500 milligram dose to be split across 2 or 3 separate infusion visits. They are equally effective, just slightly less convenient. The primary limitation of IV iron compared to oral iron is cost. IV iron infusions are significantly more expensive than a month's supply of oral supplements. However, for patients with gastrointestinal conditions that impair oral iron absorption, for patients who cannot tolerate oral iron, or for patients who need rapid iron repletion due to pregnancy, upcoming surgery, or severe symptoms, IV iron is clearly the right choice. Now, the question everyone eventually asks, can we cure this permanently? Debunking the IV iron fear, a myth that needs to die. I want to dedicate a few minutes specifically to addressing a fear that I hear from patients repeatedly. Dr. Zach, I was told that IV iron infusions can be fatal. Is that true? This myth has persisted in popular culture and even in some medical communities for far longer than it should. Let me give you the facts. First, a general point. Every medication carries some risk of adverse reactions. This is true of acetaminophen or paracetamol, which parents give their children routinely for fever. It is true of nonsteroidal anti-inflammatory drugs like ibuprofen. It is true of penicillin antibiotics. Risk does not mean dangerous for most people. It means that with any pharmacological substance, there is a theoretical possibility of a reaction in a small subset of individuals. The specific fear around IV iron centers on anaphylaxis, a severe systemic allergic reaction. In its most extreme form, anaphylaxis can be life-threatening if not treated promptly. Anaphylaxis can occur with any intravenous medication or even with oral medications. The question is not, can it happen? The question is, how likely is it, and how does that compare to other medications we accept without question? Here's the data. Allergists compile ranked lists of the medications most likely to cause anaphylaxis. If you look at the top 10 medications most frequently associated with anaphylaxis, intravenous iron is not on that list. Number 1 on most lists is penicillin and related antibiotics. Number 2 is nonsteroidal anti-inflammatory drugs that many parents buy over the counter and give to children without hesitation. Intravenous iron ranks significantly lower in anaphylaxis risk than both of these extremely common medications. Furthermore, IV iron is administered in a clinical setting, a procedure room, a clinic, or a hospital, by trained medical staff who are fully equipped to recognize and respond to any adverse reaction immediately. This is categorically safer than taking any oral medication at home, alone, with no medical supervision. The 2020 Lancet Hematology Consensus I mentioned earlier reviewed more than a decade of safety data from tens of thousands of IV iron administrations and concluded that modern formulations carry a very low risk of serious adverse events comparable to oral iron. Anaphylaxis is rare. Anaphylaxis that is serious is rarer still. And anaphylaxis that results in a fatality in a supervised clinical setting with trained staff and resuscitation equipment available is extraordinarily rare. The fear of IV iron is a myth that is preventing many women from accessing a very safe, very effective treatment. Please do not let it be the reason you avoid treatment that could give you your energy, your clarity, and your quality of life back. Now, how do we stop the deficiency from coming back? Permanent resolution, addressing the root cause. This is one of the most practical questions I get from women who have already undergone treatment. They come back to the clinic and say, Dr. Zach, you corrected my iron. My ferritin was 150. That was 8 months ago. Now it's 18 again. What am I doing wrong? And the answer is, you're not doing anything wrong. The treatment worked perfectly, but the risk factor, the underlying reason your iron was depleted in the first place, was never addressed. There is a crucial distinction between treating iron deficiency and managing the risk factor that caused it. These are two separate clinical goals that must both be pursued simultaneously for the improvement to be lasting. Think of it this way. Imagine you have a hole in the bottom of your swimming pool. We fill the pool with water. The pool looks great for a while, but the hole is still there. Slowly, the water level drops again. To truly solve the problem, you have to both refill the pool and patch the hole. Managing heavy menstrual bleeding. For women whose iron deficiency is driven by heavy menstrual bleeding, which is the most common scenario, there are gynecological interventions available that can dramatically reduce monthly blood loss. Of all the available options, the hormonal intrauterine device, commonly known as the hormonal IUD, has the strongest clinical evidence for reducing menstrual blood loss. Hormonal intrauterine devices work by delivering a continuous, low-dose progestin locally to the uterine lining. This causes the endometrium, the lining that sheds during menstruation, to become thinner. A thinner endometrium means significantly less blood and tissue shed during each period. The clinical results can be dramatic. Women who previously required overnight pads during the daytime and changed products every 2 hours often find that after a hormonal intrauterine device is placed, their periods become very light, sometimes reducing to just spotting for 2 or 3 days per cycle, or even becoming completely absent in some cases. From an iron balance perspective, this essentially turns them into someone who no longer has a significant iron outflow pipe. Their intestinal absorption is now adequate to maintain their stores with a normal diet. They become, in terms of iron risk, comparable to a man. Of course, the hormonal intrauterine device is not the right choice for every woman. There may be anatomical, medical, or personal reasons why it is not suitable or desired. There are also other options that a gynecologist can discuss: combined oral contraceptives, progestin-only pills, tranexamic acid, or in some cases surgical intervention for conditions like endometriosis or fibroids that may be contributing to heavy bleeding. The key point is, if you have heavy periods and iron deficiency, please speak with a gynecologist specifically about options for reducing your menstrual blood loss. Treating the iron without treating the blood loss is a temporary solution. The special case: atrophic gastritis. Before we leave the topic of treating the root cause, I want to mention a specific non-menstrual cause of iron deficiency that deserves attention: atrophic gastritis. Atrophic gastritis is a chronic inflammatory condition of the stomach in which the stomach lining gradually loses its ability to produce the normal stomach acid, hydrochloric acid, that is essential for digesting food. And here's the connection to iron. While iron is absorbed in the small intestine, the prior acid environment in the stomach is critical for converting iron from food into a form that the intestinal cells can absorb. When stomach acid production is severely reduced, iron absorption from both food and oral supplements is significantly impaired, regardless of how much iron the patient consumes. For patients with atrophic gastritis, oral iron supplementation is often ineffective and may actually worsen gastrointestinal symptoms. Intravenous iron is the preferred treatment and prevention strategy for these patients. A gastroenterologist and a hematologist should work collaboratively to establish a monitoring schedule, typically checking ferritin every 6 months, and administer intravenous iron preemptively when ferritin approaches the deficiency threshold. Now let's talk about food. What are the genuinely best dietary sources of iron? Top iron-rich foods: what actually helps. I want to be clear at the outset: if you have diagnosed iron deficiency or iron deficiency anemia, food alone will not cure it, but food absolutely matters for maintenance, prevention, and supporting supplementation. Once your iron stores are corrected and your risk factor is managed, a diet rich in the right forms of iron can help you sustain your levels. Let's categorize the best sources by dietary approach. For meat eaters, heme iron sources. The most bioavailable form of dietary iron is heme iron, which is found exclusively in animal products. Heme refers to the iron-containing component of hemoglobin and myoglobin, the same proteins we have been discussing throughout this video. Heme iron is absorbed at a rate of approximately 15 to 35% compared to non-heme iron from plant sources, which is absorbed at only 2 to 20% depending on the meal composition and individual factors. Red meat, beef, and lamb. These are the richest sources of dietary heme iron. Per 100-gram serving, lean beef and lamb contain approximately 2 to 3 milligrams of highly bioavailable heme iron. Important clarification: red meat in clinical nutrition specifically means beef and lamb. Pork is not classified as red meat in this context, and chicken, turkey, and other poultry have considerably lower iron content. Organ meats, beef liver. Beef liver is arguably the most iron-dense food available per serving. A 100-gram portion of beef liver contains approximately 6 to 7 milligrams of iron, much of it in the highly absorbable heme form. For those who enjoy it, liver, whether beef, chicken, or lamb, is an exceptional dietary source. Shellfish, oysters, and mussels. For those who enjoy shellfish, this is an outstanding iron source. A single serving of oysters or mussels can contain 5 to 8 milligrams of iron. These are also excellent sources of zinc and other micronutrients. For vegetarians and vegans, non-heme iron sources. If you do not eat animal products, non-heme iron from plant sources is your dietary iron. The absorption rate is lower, but it can be meaningfully enhanced by pairing iron-rich plant foods with vitamin C. Lentils, among the best plant-based iron sources. Red, green, or black lentils all contain approximately 3 milligrams of iron per cooked cup, along with significant protein and fiber. Black beans, a staple in Mexican and Central American cuisine and common in the southern United States. Black beans are an excellent source of non-heme iron with about 3.6 milligrams per cooked cup. Combined with a salsa rich in vitamin C, they become a highly effective plant-based iron meal. Tofu. Firm tofu contains approximately 3 milligrams of iron per half-cup serving. When cooked in a tomato-based sauce, it is with the vitamin C from tomatoes enhancing absorption, it is a useful iron source for vegans. Fortified foods. Many breakfast cereals, breads, and plant-based milks are fortified with iron. Check the nutrition label. Some cereals are fortified with 100% of the daily value for iron per serving, making them surprisingly significant sources. A note on pomegranates, beets, and other commonly cited iron-rich foods. These foods are nutritious and worth eating. However, their iron content is relatively modest compared to the sources listed above, and the iron they contain is in the non-heme form with low bioavailability. They are not a meaningful solution for iron deficiency, and any claim that eating pomegranate seeds will cure anemia should be regarded with appropriate skepticism. Now, let's talk about what helps and what blocks iron absorption. Absorption myths. What helps and what gets in the way? There is a lot of conflicting information out there about what to take with iron and what to avoid. Let me give you the evidence-based summary. What enhances iron absorption? Vitamin C, ascorbic acid. True. This is the one absorption-enhancing strategy that is genuinely well supported by research. Vitamin C reduces iron from its less absorbable ferric form to the more absorbable ferrous form in the gut, and also chelates iron in a way that keeps it soluble and available for absorption. You do not need a large dose. A glass of orange juice, 70 to 80 milligrams of vitamin C, or a modest supplement alongside your iron tablet is sufficient to meaningfully increase the percentage of iron absorbed. Everything else you may have heard about taking iron with X supplement to improve absorption is largely not supported by strong clinical evidence. Focus on vitamin C and correct timing. What inhibits iron absorption? Calcium, including dairy products and calcium supplements. This is the most significant dietary inhibitor of iron absorption. Calcium competes with iron for absorption pathways in the gut. If you take your iron tablet with a glass of milk, a serving of yogurt, a calcium supplement, or a calcium-fortified plant milk, you will absorb substantially less iron from that tablet. The solution is simple. Separate your iron from calcium-containing foods or supplements by at least 2 hours. Tea and coffee both contain compounds, specifically tannins in tea and polyphenols in coffee, that bind to iron in the gut and significantly reduce its absorption. This applies to black tea, green tea, herbal teas with high tannin content, and coffee. If you take your iron in the morning with your coffee, you are dramatically reducing its effectiveness. Take iron at least 1 hour before or 2 hours after coffee or tea. Magnesium supplements. Like calcium, magnesium can interfere with iron absorption when taken simultaneously. If you take a magnesium supplement, commonly used for sleep support or muscle cramping, take it at a different meal from your iron. Antacids and proton pump inhibitors, medications that reduce stomach acid, both over-the-counter antacids and prescription. Proton pump inhibitors like omeprazole or pantoprazole impair iron absorption. Iron requires an acidic gastric environment to be properly prepared for absorption in the small intestine. If you take a proton pump inhibitors regularly, discuss with your doctor whether your oral iron dose needs to be adjusted or whether IV iron might be more appropriate. The simplest practical protocol for oral iron: take it at bedtime, 2 or more hours after dinner, with a glass of water or orange juice, away from dairy, coffee, and supplements. That single adjustment will make your oral iron significantly more effective. One final medical topic before our recap. Let's briefly cover the opposite of anemia. Polycythemia. Vera, when the blood makes too much. Everything we have discussed in this video has been about conditions of deficiency. Not enough iron, not enough hemoglobin, not enough oxygen carrying capacity. But I want to briefly cover the opposite end of the spectrum because it sometimes comes up in conversations about blood health and it is worth understanding correctly. Polycythemia. Vera is a condition in which the bone marrow produces too many red blood cells, not too few. It is classified as a myeloproliferative neoplasm, which is a category of blood disorders in which the bone marrow's blood-producing machinery becomes overactive. In polycythemia vera, one of the bone marrow's precursor cells, the cells that give rise to red blood cells, undergoes a specific genetic mutation. The most commonly involved mutation is in a gene called JAK2. This mutation causes the precursor cell to begin dividing without the normal regulatory signals that control production. The result is an excessive number of red blood cells circulating in the blood. Importantly, the individual red blood cells produced are structurally normal. The hemoglobin they contain is normal. They can carry oxygen normally. The problem is simply that there are too many of them. An excess of red blood cells thickens the blood, slows its flow, and increases the risk of blood clots, a significant medical concern. Here are the key facts I want you to remember about polycythemia vera. First, it typically develops after age 50. It is not a disease of young or middle-aged adults. Second, it is a somatic mutation, meaning it is a mutation that occurs during a person's lifetime in one specific cell, not a mutation that was present from birth. Third, and this is important for anyone who has been diagnosed, polycythemia vera is generally not considered a hereditary condition. The mutation occurs in an individual's own bone marrow cells during their lifetime. It does not reliably pass through the germline to children. A person with polycythemia vera has not passed an increased risk of this disease to their children. Their children's risk is the same as the general population. If you or a family member has been told they have polycythemia vera or elevated hemoglobin on a routine blood test, this warrants a consultation with a hematologist for proper evaluation and management. Final message: your blood, your life. I want to leave you with something that I think about a lot as a doctor, something that keeps me committed to talking about iron deficiency every chance I get. There are women out there, and I have met many of them, who spent years feeling like they were somehow failing at life, too tired to exercise, too irritable to enjoy their relationships, too foggy to perform well at work, too depleted to be the parent they wanted to be. Some of them tried antidepressants. Some of them saw multiple doctors and were told their labs were fine. Some of them simply accepted it as just how I am. And then one day, someone checked their ferritin, and the number was 4 or 6 or 11. And when they finally corrected that deficiency, when their ferritin rose to 80 to 100 to 120, their world changed. Not metaphorically, literally. Their energy came back, their clarity returned, their sleep improved, their mood lifted. They described it as seeing color after years of gray. This is not a complex problem. It is not a rare disease. It is not an expensive fix. It is a blood test and, in most cases, a straightforward course of treatment. And yet millions of women are living through years, sometimes decades, of unnecessary suffering because nobody checked their ferritin. If this video helped you today, if something clicked, if you recognize yourself in the symptoms we discussed, please do 3 things. First, book a blood test, get your CBC and your ferritin measured. Second, share this video with the women in your life, a mother, a sister, a daughter, a friend. Iron deficiency does not discriminate by age between 12 and 75. Any woman who menstruates is at risk. And third, if you found this content valuable, please like this video and subscribe to the channel. It tells me that this kind of in-depth, evidence-based clinical content is what you want, and it allows me to keep creating it. If we reach 10,000 views on this video, I will do a dedicated deep dive into hereditary and non-hereditary types of anemia, thalassemia, sickle cell, aplastic anemia, and more. Let's make that happen. Take care of your blood. It will take care of you. I'm Dr. Zach, and I'll see you in the next one.